Thank you all for being here to our fourth GeroECHO series. Well, our fourth session, sorry, in our GeroECHO series on cognitive impairment. Today's didactic is going to be focusing on mobility and how to maximize your patient's mobility and function. Our agenda is basically following the same structure as before, which is a welcome and announcements and instructions, followed by our didactic session, which is going to be led today by Dr. Edna Biddy, which I'll introduce you to in a second. And we'll follow up that with a patient case and discussion, which will be led by Beatriz Videz, who is an RN at UCI Mind, with a collaborative discussion about the case that's with everyone that's here today. And then we'll follow that up with closing and reminders. Just as an update, we are CME accredited. Our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management, and to expand access to geriatric specialty care throughout California and beyond. Our target audience is you all and anyone with an interest in the care of older adults, and today's session is accredited for 1 CME credit. So if you do attend all of the sessions in the series, you will receive 5 CME credits. And we do have one more session coming up on November 6th. Just some quick house rules. Please be sure to mute yourself when you're not speaking to prevent background noise. Always try to introduce yourself prior to speaking with your name and location, and maintain confidentiality when speaking about the patient case. Be sure not to include any personal health information, and then please respect one another when discussing. Just letting you all know, this session is going to be recorded, and if you do ever need to access one of the recordings, if you can't attend one of our sessions, please reach out to me. I'll be happy to share that protected link. This series is funded by our HRSA grant. And just to let you know, this information or content and conclusions are those of the author and should not be construed as the official position or policy, nor should any endorsements be inferred by HRSA, HHS, or the US government. Our faculty do not have any financial disclosures at this time. And then we'll go ahead and move on into our quick introductions of our hub team and then our spokes. So I'll go ahead and get started again. My name is Mika Seville, and I am our GWEP grant manager here at the UCI Division of Geriatric Medicine and Gerontology, and help coordinate our age-friendly GeroECHO series. We can go ahead and move on to Dr. Biddy, who is our presenter today, and she can introduce herself before we move on to the rest of our team.
Hi, hello everyone. My name is Dr. Edna Biddy. I am a geriatrician at UC Irvine Senior Health Center, and I am starting the FALS clinic, and I hope that this lecture offers education and more ways on how to treat our vulnerable population who are frequently falling.
Thank you, Dr. Biddy. Just going to go down Dr. Sagal.
Welcome, everyone. My name is Sonia Sagal, and I'm a clinical professor in the Division of Geriatric Medicine and Gerontology here at UCI. And it's my pleasure to be with you today.
Thank you. Dr. Grivich.
Hi, my name is Dr. Grivich. I'm a clinical pharmacist. I'm a professor at USC School of Pharmacy, and I'm embedded in the geriatric clinic at UCI, where I've been since 2007, I believe. And
thank you, Dr. Gibbs.
Hi, everyone. Dr. Gibbs here, Chief of Geriatrics at UC Irvine. Thank you for joining us today.
Thank you. And I don't see any other members of our hub, so we can go ahead and move on to our spokes. Whoever would like to introduce themselves first, go ahead.
Hi, this is Dr. Kan Nguyen, family physician at Orange County Kaiser.
Thank you, Dr. Nguyen.
Hi, good afternoon. This is Beatrice Vides. I'm a registered nurse with the UCI Mind team on campus.
Welcome.
Hi, I'm Ann Ellett, nurse practitioner, specialized in dementia care here in Orange County, California.
Welcome, Anne.
Hi, this is Jennifer Rowe. I'm an emergency physician at UC Irvine, and I lead the geriatric ED program.
Thank you, Dr. Rowe. See a few others on the line. Anybody else want to introduce themselves? Okay. We'll go ahead and move on into our didactic presentation. Let's see. You can go ahead and Dr. Biddy, take it away.
Should I read the title? Okay. So today we will talk about a brief introduction of why of today's topic is mobility, how to maximize your patient's mobility and function. And we will discuss, first I'm going to give a brief introduction of the older adults and why the reasons why, the determinants of why the patient falls, the impact of a fall, risk factors. We will go over screening, assessment, intervention, follow-up, and we will also leave some room for questions. So first of all, why do older adults fall compared to a younger patient? Well, as we age, our body does become more fragile. That means we experience fragility of skin, muscle, bone, which all together will lead us to compared to a younger patient to a body that is more at risk of falling. As we age, our agility does diminish. The ability of our body to respond to let's say whenever we trip, the ability to respond or to react to a fall is diminished. Older patients do suffer from poor balance, some of them, not all of them. The medication that they might be taking might also be linked to a risk of falls, such as low blood pressure, low heart rate, muscle pain. All these factors will contribute to having a patient to increase the risk of falls, and such as in comorbidities such as Parkinson's disease, stroke, heart failure, COPD. Altogether will leave a individual to be vulnerable to a fall. According to the CDC, the places where our patients fall more frequently are at home, being 60% of the times, community 30%, other such as a hospital, clinic, a nursing home, rehab facility, that includes 10% of the time. Now in times of pandemic, patients are falling more frequently, more so at home than the community. But by far, home is the most common place where our patients are falling. The different types of fall, ground level is the most common one with 43%. The second to falling from a stairs, steps, curb or sidewalk falls, falling from a chair, bed, furniture, and other will compromise 30%. By far, ground level fall is the most common type of fall in our elderly population, which is important to know the mechanics of a fall to know what to target. From the patients that do fall, 20 to 30% will have a serious injury. Serious injury meaning a hip fracture or brain trauma. And it is also said that the most common cause of traumatic brain injury in the elderly is due to a fall. And then it is also well known that compared to 2007 and up to 2016, that's where as far as the data goes on the CDC, there has been an increased mortality linked to falls. That does have to do that our patient population is aging. That the group of patients that reach the geriatric age is larger than it was before, and our patients are living longer, which the longer that we live, the more frail the patient becoming. All these contribute to an increased mortality and increased rate of falling. There's also a financial cost to a fall. Falls tend to be very expensive. In average, it is said that per patient, every time that a patient falls, there's an average cost of $30,000 per patient. And in a year, in even 2020, $50 million were spent on patients that were frequently falling. And as we can see, there is not only a health impact, but also financial impact. And this is all important. And it's important that we talk about falls and to talk about how to prevent falls, because overall, some of the falls or most of the falls can be preventable, and we need to find ways or solutions on how to prevent these falls. According to the CDC, there's risk factors will be divided into intrinsic, or what's pertinent to the patient, and extrinsic, that's more related to their environment. Speaking of intrinsic factors, that would be advanced age, a previous history of falls, which is the most common or the risk factor that is most commonly associated for a patient to have recurring falls. Also, the fear of falling is said that it's a high risk factor for a patient to continue falling. Muscle weakness, gait and balance problems, having a poor vision, postural, hypotension, in medical conditions such as arthritis, stroke, incontinence, diabetes are some of the examples of risk factors that for a patient to fall. As far as extrinsic factors that we can say is these are mainly the environmental factors associated to the patient, such as lack of stair handrails, poor stair design, lack of bathroom grab bars, dim lighting or glare, slippery surfaces, medication, improper use of assistant devices. And as you can see, most of these extrinsic risk factors are associated to the patient's living environment or home. In knowing that home is the most frequent site of a patient to fall, it's important to address the patient's home environment. There are drugs that are more highly associated for a patient to fall, for a patient that is falling frequently. The most studied or most well-known medications are benzodiazepines, and that's one of the biggest reasons why geriatricians try to stay away from benzodiazepines, but diazepines as much as possible. But there are other medications that are included in this group of medications that might put a patient at risk of falling, such as cardiovascular disease medications, antidepressants, anti-epileptics, antipsychotics, anti-Parkinsonian drugs, opiates, urologic spasmolytics are part of the medications that are linked to a risk of falls. So, it can become tricky thinking of medication management or medication tailoring for a patient that is falling, because some of these medications we might not be able to completely discontinue or taper, but we have to find strategies on how to prevent this patient from falling. So medications are, although we know that are a big contributor to a patient that is falling, we have to find a balance on how to treat the patient, but also prevent them from falling. Other risk factors that we have to also keep in mind are elderly abuse, alcohol use, dehydration, and malnutrition. So how do we assess a fall? First, we need to start with screening a patient for the risk of falls. Then we will going to move to assessment, and then we will discuss different interventions on how to prevent this patient from falling. So there's two ways to do the screening. One is through a self-assessment. It's a series of questions that are linked to risk factors for a patient to fall. If the patient answers to more than 4 of these questions, if they answer yes to more than 4 questions, that is considered a positive screen, and then we are going to move forward to the next step. The other way of screening, of considering a positive screen, is if the patient tells you that he or she has fallen more than 2 times in the last year, the patient presents with an acute fall, or the patient tells you that he or she has difficulty with balance, then that is automatically considered a positive screen. And then, of course, in all medical conditions, it's important to get a good history and do a good physical exam. And there's some labs and imaging that might be beneficial in this case. Specifically focusing on falls, we have to get ideally a very good history of the fall, because if we do a very thorough or detailed history, we will be able to pick up on factors that might be contributing for this patient to fall, and that's where we can implement an intervention. We have to have a good medication reconciliation. Oftentimes, or when we see patients in the clinic, the list that we have on the system and the list of medication that the patient is actually taking are different. So we have to have the medication list as clean as possible, so we can identify possible medication or polypharmacy that we can intervene and make changes. As far as physical exam, things that we can look into is orthostatic hypotension. We can look into visual impairment, nystagmus, musculoskeletal, especially footwear. We often miss patients' footwear, and there are times where their shoes are not fitting correctly, and that is contributing to falls, or their footwear might be too slippery. We need to do a detailed neurologic examination. It will give us an idea of where the patient's reflexes are, or how much mobility they have. We need to check their cardiovascular status. And as far as labs and imaging, we usually just go for the routine CBC and CMP. And as far as imaging, if we are assessing a patient that is at risk of fall, having a DEXA scan is always very useful. In the office, 3 tests that we can do to assess how the patient, how their mobility status is the time up and go test, the 30-second chair stand, and the 4-stage balance test. From all these 3, if our time is limited, one of the tests that is recommended is going to be the time up and go test, which basically what it is that we have the patient sit on a chair, have them to walk 10 feet, turn around, go back to their seats. We need to time the time that it takes the patient to do the whole test, and then we need to chart it and plot it according to their age. It will vary depending on the age of the patient, but in general, more than 12 seconds is the cutoff to say that the patient is at risk of impaired mobility. We have a 30-second chair stand, and we ask the patient to cross their arms and have them to do stand and sit down as many times in 30 seconds. You count them, and you want to reference to their age group. And the 4-stage balance test, which is you have the patient to stand with both feet, 1 foot in front of the other, and then the next step would be doing a line with both feet, and the fourth stage is having them to stand on one leg. And if the patient is able to complete this test, then you can be confident that at least their balance is very good. If a patient is not able to do, let's say, to the side feet, you usually don't move forward with the next step, because you don't want to put the patient in danger of falling. So what is the next step? Once we know that a patient has screened positive, and once you have done a physical exam and you know that this patient is at risk or has a mobility problems, at risk of falling, so what would be the next step? So first we need to, okay, move on to the next slide. We need to risk stratify the patient. You want to know whether this patient is at low risk of falling, at moderate risk of falling, or at high risk of falling. Depending on what category this patient falls under is the interventions that are recommended. For example, if you have a patient that has that on the stay independent brochure or the self-assessment scores more than 4, or if the patient tells you that they've had a fall in the last 12 months, then you would want to move down to evaluate their gait and strength and balance. And then if you notice that the patient doesn't have no gait, strength, or balance problem, or if the patient scored a less than 4 or no to all the questions, you will stratify the patient will fall under the low risk category. So when the patients are in the low risk category, the interventions that we recommend are to educate the patient on the risk of falls, to assess their home environment ideally, check for the vitamin D levels and calcium. And if the vitamin D levels and calcium is a controversial topic, because years ago, it was said that it was associated to a decreased risk of falls. And more recently, the data has showed that there's no association. The reason what I personally like to order vitamin D level and calcium is mostly thinking associated to treatment of osteoporosis. Because it is, the research has shown that if this patient who is at a low risk of falls, but it also has osteoporosis, and you want to start treatment, if you start with a normal baseline vitamin D or even a higher than baseline, the response to treatment is better than the patient that you start with a baseline vitamin D lower than the desired. And also indirectly associated, vitamin D and calcium is going to strengthen patients' bones and muscles, and is not directly related to a fall, but indirectly. So it is always recommended in that way. And you always want to refer the patient to strength and balance exercises in the community mainly. And this is in patients who fall under a low risk are mainly in the preventive category. You want to prevent this patient from being a frequent faller. Now, on the contrary, if you have a patient who has scored positive on the screen who you've detected that the patient has a impaired gait, strength, or balance, then you want to, the next question that you should ask, or the information that you should get, is how often is this patient falling? Is the patient has had more than 2 falls or a fall with injury? Then you want to move on to conduct a multifactorial risk assessment. And what it includes is that you want to be very detailed on your falls history. You want to do a detailed physical exam, mainly focus on postural dizziness, postural hypotension. You want to do a medication review, a cognitive screening, feet and footwear check, and use for mobility aids and visual acuity. And this patient will fall under the high risk category. These patients, we usually like to do a close follow-up, thinking that once we implement a plan for the patient, let's say that we we discontinue the medication that we can possibly discontinue or taper that are causing dizziness or postural hypertension, we refer this patient to physical therapy. We have done we make sure that their vision is adequate, their hearing, their footwear. You want to make sure that once you have implemented these recommendations, that there's actually a follow-up. That's the reason why you want to see these patients 30 days after the initial detailed comprehensive falls assessment. Now, there's another category, which is the high-risk individualized fall intervention. These are patients that who have tested positive for a screen, who on the physical exam, you notice that they do have gait, strength, and balance impairment or issues, but who've had 0 falls or 1 fall with no injury. In these patients, you want to optimize or work around the risk factors that have been encountered, and you also want to do a 30-day follow-up for these patients. But the most critical of all the patients are the ones that are frequently falling, more than one fall, and who've had injury. Because in these patients, you have to think about that they will be exposed to a higher mortality compared to a low-risk patient. It is also important or encouraged to do a home safety evaluation if it's possible and if it's available, because oftentimes you can find things that you can modify or change in the patient's environment to prevent this patient from falling frequently. Any questions on that, on the algorithm? Okay, I'm going to reserve it to the end. Can we move to the next slide? And after you implement an intervention, ideally the follow-up should be within 30 to 90 days, because you want to encourage adherence to your recommendations. And if there are any barriers to the achieving a common goal, you want to be able to detect them on time and see what those barriers are to create changes. So create a strategy that is that's suitable for that patient case. All patients who are falling or frequently falling or at risk of fallings will have different situation, living situation, or even their comorbidities might be different. So every plan should be individualized for this reason. There's no one size fits all. It's mostly a tailored treatment plan depending on what the patient's needs are. And that's all.
Does anybody have any questions for Dr. Biddy?
I was just wondering where that algorithm is from.
This is from the CDC.
Okay.
It was just published this year. It's on the CDC. The CDC has great resources also in brochures that you can give to patients of information and ways how to educate them to prevent a fall. But it comes from the CDC.
Great, thank you.
And this is the study tool. It's I can forward it to you. I have it on my computer, so I can forward it to everybody if you like.
Perfect.
Okay, any other questions before we move into our case overview? Okay, we'll go ahead. So thank you, Dr. Biddy, and I wanted to especially thank Dr. Biddy because today is, I think, her vacation day, and one of our members of our hub team was originally supposed to be presenting today, but due to the fires in Napa, was not able to do so. So thank you so much for stepping up, Dr. Biddy, and presenting our didactics for this session. Enjoy your vacation. So we have Beatriz Vides, who is an RN at UCI Mind, as she introduced herself earlier today, and she did submit a case for us today. So I'll go ahead and share my screen. And Beatrice, you can go ahead and start with the summary. Give me 1 second to pull that up. Okay, hold on 1 second. Can everybody see the case?
Yes.
Okay, great. Okay, we can go ahead.
Okay. Thank you for allowing me to present. This is actually a case study that I put together based on my mother, because I don't see patients for mobility reasons, but I thought this was a pretty recurrent case that we do tend to see in the office. So I'll start. The patient is a 68-year-old Hispanic female, monolingual Spanish speaker. And the main question for today is, are there any other treatment options that could be available for this type of patient? The patient has not attempted any physical therapy, but wants more aggressive treatment. I'm sorry, I'm going to go down to my past medical history. So the chief complaint is radiating pain and numbness in bilateral lower extremities since March of 2020. Recent past medical history includes a bilateral L5-S1 transforaminal epidural steroid injection on 10/7/2020, history of diabetes, hypertension, right breast cancer with mastectomy in 2018, TIA, osteoarthritis, I forgot to include osteoporosis as well, and hyperlipidemia. The patient has no known medication allergies, and I did include a list of medications. It's on a separate slide, which is quite long, and I won't read through those, but you're welcome to just kind of scan through those. And there's no known history of dementia. And again, the main question is, so in addition to new medications which were prescribed for this condition, which includes the gabapentin 100 milligrams, PO, QHS, undergoing the epidural steroid injection, what other options might be available for a patient like this who does not seem to have gotten resolution to her sciatic nerve pain?
Could I see the med
Okay.
list one more time?
Sure.
Can you share just a little bit about the workup of how the diagnosis was made of sciatic?
Sure. The patient did undergo an MRI of the lower lumbar spine, and I can bring that up actually, but I won't be able to share it with you, but I can read the findings to you. Give me 1 second. So the MRI of the lumbar spine without contrast, it's loading. Impression, multi-level degenerative changes of the lumbar spine, including possible spondylolysis with grade 1 spondylolisthesis at L5-S1 through the pars. I'm sorry, I'm going to butcher half of these things. Interarticularis regions are difficult to visualize on the current MRI. Degenerative changes are most pronounced at L4, L5, where there is also an anterolithisis with disc bulge facet arthropathy, and ligamentum flavum thickening, causing moderate to severe stenosis of the spinal canal with lateral recess narrowing. Moderate spinal canal stenosis is seen at L5S1. Secondary to degenerative changes with left greater than right neuroforaminal narrowing. So that was an MR of the lumbar spine. There was also an X-ray of the hip, bilateral with pelvis. Bringing that up. The impression, no acute fracture or significant degenerative joint disease of the bilateral hips, but the findings include alignment of the bilateral hips is normal. The bilateral hip joint spaces appear preserved. No acute fracture. Ovoid sclerotic focus at the right femoral head neck junction is favored to represent a bone island. Mild degenerative changes are noted at the pubic symphysis. Sclerosis at the right sacroiliac joint, predominantly on the iliac side, may represent osteitis condensans. Evaluation of the sacrum is limited, secondary to overlying bowel gas and fecal matter. Lower lumbar degenerative disc disease is incompletely evaluated. Atherosclerotic ossifications are present. And I think, sorry, go ahead.
Sorry, do you know what the physical exam shows?
I don't, I'm sorry. I don't have any findings from the physical exam.
Do any of our participants on the call have any questions regarding the case?
Well, I have medication questions, but I'll wait for everybody else to chime in with theirs.
I'm sorry for the incomplete information.
I had a question for the pain the patient's having. Can you go up again to see what pain she's having and where it's the distribution of pain?
So the pain is occurring at both of the buttocks, right in the middle point of each of the buttocks, and it's radiating down to the feet on both sides.
Okay. All the way to like the toes?
All the way to the toes, including the numbness.
Any weakness?
No.
And so it's numbness and pain shooting downwards. And is it more posterior pain or like more anterior thigh?
It's posterior. Posterior.
Okay, thank you.
And what does the patient mean by she wants more aggressive treatment?
What she means is she feels that the steroid injection didn't provide her with much resolution to her pain. The numbness is improved, but because her pain is not improved, she feels that it didn't work, that this isn't the right treatment for her.
Do we have a PHQ-9? Oh, sorry.
I was just gonna say, did she give any clues as to what kind of treatment she was looking for?
No.
Okay.
Has she tried physical therapy yet?
No, she's not tried physical therapy. And I don't believe it was, I don't know if it was given to her as an option by the orthopedic surgeon who saw her.
Is there a PHQ-9?
It was not done as far as I know.
Can I go over the meds? Can I ask you questions about the meds?
Sure.
Okay, so can you pull it up again? So Tylenol, does she take 3 grams daily on a daily basis on a schedule?
No, it's not scheduled. No, it's just as needed.
How often does she take it?
Typically morning and night.
Okay, is she not in pain during the day?
It's not as bad during the day. It's the worst in the morning. And then, of course, as the day is kind of winding down.
And so when she takes the Tylenol, does she feel any relief?
Some.
Okay, so let's keep going on the list. The baclofen, is she doing that every night?
No, she doesn't do the baclofen. She complains of feeling too groggy
Okay.
in
So
the
she does,
morning.
so she doesn't use it. So she's groggy in the morning when she takes it at night.
Mm-hmm.
Okay. Keep going. Um, the vitamin B12, is her B12 level normal?
B12 level is normal.
Okay. And the diclofenac gel, does she use a little measuring stick to measure out the dose?
To be honest, she does not use the Voltaren gel. She doesn't feel that it provides her any benefit, so she stopped using it.
Has she, when she used it, did she use the measuring stick or did she?
No.
Okay.
It was just.
Okay. And then the gabapentin 300, she takes that every night. So you said 100 when you presented, is it? It's 300?
Oh, I'm sorry. It's 300. I apologize for that.
Okay,
It's 300.
that's fine. And so 300, is it doing anything? When she started it, did she notice any improvement?
She did not notice any improvement, but also complained of feeling groggy in the morning, having a more difficult time getting up in the morning. So she is starting to become reluctant to take the gabapentin.
Okay. And then is there anything else on the list? Oh, and ibuprofen, is she using that?
No, it was prescribed for pain, but she does not take the ibuprofen.
Why?
She doesn't like it.
Do you know why?
I think it's more of a gastrointestinal, like it gives her some gastrointestinal discomfort.
Has she ever tried any other oral NSAID like
Naproxen?
Did that work any better?
Yes, she likes the naproxen.
Okay, and how much does she take?
I think it's just one tablet, so 220 milligrams in the morning.
So the over-the-counter dose?
Just over the counter.
Mm-hmm. Okay. And her kidney function is okay?
Yes.
Okay. So just based on what you've said, in terms of meds, you can certainly do more Tylenol. You could take that extra tablet during the day. You could even, if she's in pain more at night, you can take 2 tablets at a time. So you could, you could do, as long as you're staying within the 3-gram maximum on a daily basis. Mm-hmm. Honestly, I would really give Voltaren gel another shot and really measure out that dose, because when you see that ruler, and you can get a picture of it online, 1.25 inches or 2.5 inches is quite a bit of gel. And if you apply all of that in, it might actually absorb enough to take the edge off. I think
would that application be per
time?
side?
Each time. You can do it 4 times a day.
To each location, so like right side and left side?
Yeah, you could. It's fairly minimally absorbed. In my experience, I have not seen systemic side effects from it, and it can provide some relief. In terms of, if 300 of gabapentin is making her sleepy, I don't know that I would increase the dose, especially if it's making her groggy in the morning. But you could back off to 200 or 100 at bedtime and see if a lower dose, again, helps a little bit, without causing the grogginess in the middle of the day. And then in terms of the NSAID, they're all really individually tolerated and effective. So if you think naproxen it helps her, if it takes the edge off, I would actually, you could do 2 tablets at a time. If that doesn't work well enough, or if it upsets her stomach, you could try another one like celecoxib, Celebrex, or meloxicam, provided her kidney function is stable, and she's already on a PPI, so that should protect her stomach. The other couple of things I would consider is lidocaine topical. They come in patches, 5%, or over-the-counter 4% patch cream, ointment. I think it comes in that. So massaging that in twice a day could be really helpful as well. And then especially if she's got a mood disorder of some sort, you could try duloxetine, because that's also really helpful for neuropathic kind of pain and mood. So that you could kill 2 birds with 1 stone. So I would start with duloxetine low dose, 20 to 30 milligrams a day, and kind of titrate up monthly as tolerated and as you're seeing. But I don't, and the other thing I would do is just kind of set pretty definite goals for what to expect. Because I think if the expectation is that she's pain-free completely, that might not be realistic. But if it takes the edge off, if all these things take the edge off enough for her to be able to be more functional, I think that's a start. Sorry, I've talked a lot.
No, it's very helpful. Thank you.
But I would also encourage her or explore the physical therapy option, because often patients with sciatica can get a great deal of relief from physical therapy, like targeted therapy to the region, maybe strengthening the core, and maybe she can avoid medications doing that, certainly long-term medications. Because in my experience, patients with sciatica, the sciatic pain doesn't necessarily last, for months and months and months. If they can get some physical therapy, they can get out of pain, they can learn proper body mechanics, and learn kind of the things that trigger the sciatica and learn how to avoid them. And then you can avoid the medication use as well.
Okay.
And one other thing I just wanted to ask is in terms of her diabetes. I'm assuming she's diabetic because she is on glyburide and metformin.
Yes.
And the pain that she's having, I want to just make sure isn't related to diabetic neuropathy. So I don't know if that's been looked at or.
I mean, there may be some overlap, but the pain, the radiating pain and numbness down to her feet really did begin when she started having that sciatic nerve pain.
Okay. And the pain is bilateral?
It is.
Okay.
And it's left greater than right.
Okay. Thank you. Any comments from the participants on the call?
I was also curious about the diabetes status. And also because I think you mentioned when she had the spinal injection that the numbness improved, but she still has pain. And I would just be curious as to if the characteristics of the pain changed after the injection, because you mentioned some calcifications on the x-ray that might suggest maybe some arterial disease in the lower extremities that could also be causing pain. So if these other methods, physical therapy should improve the sciatic pain, and the medications that Dr. Gervich suggested should be improving pain if it's musculoskeletal. But if she's persisting with pain despite all these other treatment modalities, there might need to be some investigation into her circulatory status of the lower extremities.
Okay. Now I have a question. Her physician, her orthopedic surgeon is planning on doing another epidural injection, but just going a bit higher. And I apologize, I don't know exactly where they're recommending to do the second epidural injection, but they did say they're going to go a little bit higher in the spine. Is there any downside to undergoing so many epidural injections?
From what I've seen in practice, that's like the treatment of choice, as long as it's being well tolerated and spaced out far enough, until it's no longer controlling pain, because then usually from that point, they have to start considering like surgical options.
And how long, what's the spacing? Could it be months, or is that it depends on the patient's needs? Every month, every 2 weeks? What does that spacing look like as far as a safe amount of time in between injections?
I think that depends on the medication being injected.
Okay.
anybody have any other suggestions or questions for Beatrice?
I think I would just, and this Dr. Rowe, just wanted to echo Dr. Sagal about the PT. As a ED physician, I can't, follow up on patients all the time, but we see a lot of patients with back pain, sciatica, and just from personal experience, I can't recommend PT enough. And we've heard stories from patients who say like, no, I really did it and it did really help me. I would just encourage your mom to keep at it and have a real plan. And then also incorporate any kind of activity that she can tolerate. I know we talked about like pool therapy before last week. And I think all of those things can only help in addition to all these things, because, we would want her to try everything besides adding on more and more medication.
Mhm.
Yeah, I would third that. There's nothing that really can replace toning of muscles and supporting structures in the back and the abdominal muscles as well in people who have sciatica. So that whole, lifestyle and exercise elements of range of motion, strengthening, stretching is incredibly important. So, I mean, if she can and the pain allows, this patient should really start what will be a lifetime of, exercises that do range of motion, stretching, and strengthening.
Okay. I have one more question. Does she wear a back brace?
She only does it on occasion if she's going to be doing any strenuous activity like house cleaning, or if she's babysitting my son who's on the heavy side. Then she will wear a back brace, but on a regular basis, no.
And does she do a lot of sitting?
Post-pandemic, yes.
Okay.
Pre-pandemic, no, she was very active.
Oh, I see. Because I would imagine that it would worsen during pandemic when everyone's sitting. There are, I mean, I don't know what everyone else thinks, but I think it is recommended to wear back braces even with sitting, but there are other ergonomic like strap devices that help put pressure off of the lower back while sitting as well. And I know that can be helpful as sometime. I don't know the specific brands, but it almost looks like a back brace, but it can go over knees and it can help. It can just help patients, have relief of pain on the lower back.
Okay, I'll look into that. Thank you.
So I just have one quick thing. I work with a bunch of OTs at USC that really do a lot of pain management. So the non-drug, not necessarily exercise pain management, but more day redesign around when things flare up. They give you activities to do. And so sometimes having that separate referral to PT and OT can give you more options, I think.
Okay, perfect.
Any last recommendations? Thank you so much, Beatriz. That was such a wonderful case. Let's go ahead and close out. 1 second. Let's see. Okay, can everybody see this? Okay, so we are going to go ahead and close out our session. I know we just have a few more minutes. Thank you all to Dr. Biddy and Beatriz for today's session. As you all know, we'll go ahead and receive an evaluation after this session. Please go ahead and fill that out. We do use those recommendations to help plan future series, so we definitely appreciate your feedback. And if you do want CME or CU credits, you'll want to definitely fill out that evaluation. We are always requesting new cases, so you will also receive that fillable case template in that email. If you do have a case to submit, please do so. We have one more session that is taking place on November 6th, so in 2 weeks, and that topic is going to be focusing on what matters most, major transitions, end-of-life care, and respecting your patient's life goals. And our hub team member, Camille Fitzpatrick, who's an NP, will be presenting that didactic session. This is going to be our last session in our first series, and we do plan to have another series starting in the new year. So we will definitely let you know when that will be launching and what the topic's going to be focusing on, but it will definitely be under our age-friendly umbrella. So I thank you all so much. Does anybody have any last-minute questions or anything that they'd like to add before we end today's session?
Yes, this is Dr. Nguyen. I don't know whether this issue will be addressed as our last session, but when I think of mobility and functional assessment, the most challenging issue for us is typically determining when elderly patients should stop driving. So I hope in our last session, we'll be able to address that issue.
Great
Thank you so
suggestion.
much, Dr. Nguyen.
Yeah, great suggestion. Thank you.
Thanks.
Anything else?
I just wanted to thank everyone for the robust discussion today. Thank you.
Thank you all so much. Again, look forward to the email that I'll go ahead and send after the session, and we hope to see you all on November 6th. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.